Welcome everybody to today's Telehealth Secrets webinar. My name is Anne. We have a special program for you today. We'll be talking about how you can access billions of dollars of grant funding through telehealth and broadband partnerships. So whether you're in healthcare or broadband, this is for you. So with us today to help us do this is our guest moderator, community broadband expert, Craig Settles. Craig is an independent consultant and analyst in this space for almost 15 years. His clients have included the state of California, Calix, and Juniper Networks. He also hosts his own podcast show, Gigabyte Nation. Something you might not know about Craig, he was saved from a stroke by telehealth, and he is now paying it forward by assisting communities build their broadband and telehealth strategies, plans, partnerships, and initiatives. And with that, I'll go ahead and turn the rest of our time over to Craig.
Thank you very much, Anne. I appreciate being here and having the opportunity to speak with your audience. The FCC, the Department of Commerce, and several other federal agencies are offering billions of dollars in grants and loans to help get telehealth and high-speed internet access into every part of the country. I'm very excited to be here today with our two guests who have led teams through the FCC's COVID grant bidding process. They will discuss some of their experiences working through that grant process, and their insights hopefully will help you get some of that money from the various other government grants. Jean Polster is the CEO of Neighborhood Family Practice in Cleveland, Ohio. Jean's team was one of the first to get some of the COVID-19 grants for telehealth from the FCC, and we'll be hearing from her later in the program. And our other guest is Geoff, who is Senior Program and Operations Officer at the Enterprise Center in Chattanooga. Geoff's team partnered on a grant with Chattanooga's public broadband network and Leo Healthcare and Hospice to deliver telehealth to a 3-state service area. Geoff, take it away.
Craig, thanks so much for that introduction. I really appreciate it. I'm Geoff. Craig mentioned I work for the Enterprise Center. We're an economic development partner to the city of Chattanooga and Hamilton County. Note that is not a healthcare provider or a telehealth organization. We are a community partner, and I hope to kind of walk through a little bit of what a community partnership model can mean for folks interested in this space. Our mission focuses on uniting people, organizations, and technology to build an advanced and inclusive future for our community. We do that in a couple different ways, focused on our innovation district and innovation ecosystem through research and application development around the gig and the fiber network that we have here in Chattanooga, and then through digital equity, making sure that our entire community has access to these assets and the opportunities associated with the 21st century and connected communities. Our role in telehealth prior to COVID-19 really did focus on some of those smart city applications, as well as startups and entrepreneurs working in the healthcare space, as well as integrating health information into our digital literacy programming. In response to COVID-19, though, we found ourselves increasingly in this sort of technical assistance space for industry and community partners for whom suddenly telehealth was what they needed to be doing. As well as expanding that support for individuals utilizing telehealth for the very first time. As Craig mentioned, our application was in partnership with a couple of other organizations, EPB, the Electric Power Board, our municipal utility and internet service provider, and Leo Healthcare, which includes in its portfolio Hospice of Chattanooga, a rural healthcare provider and hospice entity with a 3-state footprint. And the focus of this grant was on 2 particular service lines. One, palliative care, those individuals who are 5 to 7 years from hospice themselves, who have a chronic condition, who may need pain management, and have a care plan, regularly meeting with a physician or other healthcare provider, but for whom the drive of more than an hour to visit one of those was a barrier, who we want to make sure stay out of emergency rooms, and who are in a danger zone for the effects of COVID-19. The second part of that was around their grief services and telemental health. Some of that provided through hospice and directly through Medicare, and some of it in partnership with other community organizations like our school system, providing those grief services to families. So my hope is to kind of walk through kind of where we were and how we got into the FCC space, some of our lessons learned from this pretty big grant opportunity, and then some bigger picture lessons from a couple of other grants we've been through and these community partnerships. So number one, community convening quickly brought to light a number of different partnerships for us. How that came about was, as the city shut down, our United Way stood up a daily call that brought in more than 150 organizations to share opportunities, challenges, what they're facing, turned into a number of different working groups and focus groups who were able to collaborate with one another, share these updates. And this kind of tapped into networks that we didn't have before. Same for other partners. The funding opportunities that came out of this became those sort of galvanizing moments. How we could actually practically work together now that we knew what the challenges and opportunities each of us had in this space. And so that's something that I would encourage her. What are those things that are bringing your particular community together? How can you listen and how can you offer help and find something like this that allows you to do that work in conjunction with one another and meet these shared challenges? I think the other part of it, as we thought about not just the current crisis, but resilience and recovery, is that it's possible to do this work to solve for the current crisis, absolutely essential, while looking to what can happen in the future. One of our partners in Chattanooga, a different hospital who actually applied for this grant, talked about telehealth really being an edge case for them to begin with. It was where they did some of their most innovative work, how they reached out to clients and patients who wouldn't normally have been able to access their services, but it was not how they did things every day. As everyone pivoted to telehealth being the only way to provide service, they recognized how it could fit in well after our current crisis was over. And I think that mindset is really important in thinking big picture. On the FCC opportunity itself, just wanted to share a couple of sort of lessons learned and as aphoristically as possible. So the first thing was this idea that you don't know what you don't know, but somebody might. One of the biggest challenges just practically to completing these grants for us and for that hospital that I just mentioned was that I believe it was 56 different practices within that hospital required registration in order to move that grant through. For our smaller footprint, that was still 7 different practices within Aleo Healthcare that had to be registered. We found out because our partners at the hospital let us know this is going to be something you're going to come through, and they knew because one of their out-of-state partners let them know. I think that's really important for collaboration in general, is that we as a community didn't see this as us competing against other organizations applying for these funds. We looked at it, what's going to help Chattanooga, and that's us working together and making sure that we're all able to work on this. To that point too, with potentially similar technologies and use cases, it can be hard to stand out. We know that some of the end user equipment, as well as some of what the doctors themselves are using, is going to be very similar. And so that shopping list may be the same, but in the grant opportunity. But for us, crafting that community narrative, why are we the right people? And what is it that makes this different and an opportunity to learn something? So palliative care, dignity of life, aging in place, rural healthcare, these were all really important aspects of telling our story. Something that I think is true between telehealth and broadband is this idea is if you build it, people will come is not the right approach. making sure that you're keeping your focus on that end user and making that access and infrastructure meaningful is important, not just to sort of community health outcomes, important to being able to provision service and get paid for it. But again, this sort of overall ability of this to move forward. From a grant writer's perspective, rigid structure and scope can still be an opportunity to really think creatively. What can this grant do? But what else do we need, and where can we find that? And this grant was definitely that kind of process for us. And we looked to other partners to meet some of those needs, particularly around what our users would need beyond access and the technology. Finally, I think it is really important to be kind to both yourself and your partners in a collaborative process like this. This was as folks had to pivot to telehealth, many for the very first time as their primary way of doing business and providing service, that as we tried to answer some of these questions for this specific solicitation, it was the first time that our partners at hospice had to answer those questions and figure out who knew the answers and how we could build this thing together. So, we could have just slammed our foot on the accelerator, but for the long-term health of this partnership and knowing how important telehealth is going to be to our community moving forward, making sure that we were looking out for our partners and doing it in a way that worked for them was crucial. Just quickly, big picture, I think these things are important and allow for some different funding streams. So the digital divide is a public health crisis. The ability of the end user to actually access these platforms and take advantage of all of these opportunities really depends on certainly their ability to access the internet, certainly having the technology in their home that can use it, but also knowing how to make it meaningful, feeling comfortable using it, trusting the partner on the other end. And that's a big piece around closing this digital divide and its impact on health in general. Trust and trusted partners are absolutely essential. And I think this is from that community approach, how do you bring those partnerships together? Who is also working with your client base, your patients? Who is the trusted nonprofit, the church, the community organization that you can bring in to make sure, again, that it's not just we've got the service, but nobody's using it, but that long-term relationship between you and patients. We have another hospital here in Chattanooga that has taken that to some really interesting levels, thinking about building renovation and streetscapes in the neighborhoods around their hospital, building up that long-term relationship with families that will have lifelong relationships with their healthcare provider. Finally, and I think this is really important, is the FCC opportunity was incredible. Sometimes there are some smaller opportunities that you can go after that end up leading to that next thing. It's really important for groundwork. We had one where we were able to get a little bit of equipment to put into senior centers around the region so that seniors would be able to come in, take a telehealth appointment closer to their home, but B, really learn that equipment so they could be comfortable accessing from home, know someone, trust someone in answering some questions. So that's what I've got to share. I'm really looking forward to the conversation later, and I'm especially looking forward to hearing from my co-panelist here, Jean. Chattanooga has been so impressed with the work happening in Cleveland, both in terms of healthcare and around the digital divide. So I'm going to stop talking for a second and listen and learn. Kick it over to you.
Hello, Jean Polster again, and I work at Neighborhood Family Practice. I'm the CEO. We're a federally qualified health center in Cleveland, Ohio. I think there's going to be some slides here in a second that tell a little bit more of our story. But while we're waiting for that, I'll just tell you when we started this journey when COVID hit, we had done absolutely no telemedicine at all. And there's nothing like a pandemic, to cause a revolution in terms of the way that we deliver care. And so I want to tell you a little bit about the work that we've done since then, but also just to set the stage so you understand the type of organization that we're looking for. If I could have the next slide. Thank you. So we're a federally qualified health center. For those of you who are not familiar with federally qualified health centers, they're one of the best kept secrets in terms of primary health care in the US, with 1,200 plus locations across all 50 states. And we're the largest provider of care to folks generally who otherwise might lack access, and that's for both urban and rural locations. We're one of 6 health centers in the Cleveland area, and there's over 50 of us in the state of Ohio. In our part of the city of Cleveland, we're the biggest and only FQHC. We've been around for 40 years, but over the past few years, especially in the advent of the Affordable Care Act, we grew very rapidly and also merged with a charitable clinic. So now we have 7 locations, and those locations all have primary care, behavioral health. I'll talk about that more in a bit. But we also serve a very diverse population. If we could have the next slide, I'll talk about that for a second. So our practice, we have primary medical care. So we're like a big doctor's office for all ages and stages, including offering midwifery care for pregnant women. We have behavioral health service. It is not a service for folks that need a lot of care and who are severely mentally ill or requiring front-end substance abuse treatment, but we take care of the walking wounded, I say. So many people living in poverty have a lot of issues with trauma and anxiety and depression, and we care for that with both prescribers as well as therapists. I mentioned the women's health. We have a small dental program. We have our own pharmacy. We do a lot of wellness activity. And we're also the only refugee service provider. When there was a flow of refugees into the country, we were the primary healthcare, first healthcare they would see as they entered our community. And then we also help sign people up for benefits, get them on Medicaid, get them on our sliding scale if they're uninsured and don't have access to Medicaid. We are a Medicaid expansion state in Ohio. If I could have the next slide. So we served 21,000 people, and I think that when we talk about what we're trying to do, you know, I often, when I've looked at what we've tried to do with telemedicine, I keep thinking about those 21,000 people and how are we going to reach them in a pandemic? And I'll talk a little bit more about that. But that's my true north is like, okay, you know, when this pandemic first started hitting and it wasn't safe to bring people into the office, how are we safely going to care for 21,000 people? Again, that was, I think, something that really drove my clinical leadership to do the pivot to telemedicine that we'll talk about. And as I've said, we have, not only do we have a refugee community that we're serving, but we also have a lot of Spanish English folks whose primary language is Spanish. About 27% of our patients are from the Latino community. Over 80% of our patients live below 200% of the federal poverty guidelines. So, you know, we have a community of that we have some, you know, who have means, who are very used to using technology, but we also have a lot of people who are either living in poverty, but they own a smartphone, we'll get to that, or, you know, in many cases, they actually have language barriers as well. So if we can have the next slide. So when I will never forget March 9th, when the first COVID case came to Ohio. Our county was first in Ohio to have diagnosed COVID cases. We had 3 on March 9th, and even though telemedicine had been in our strategic plan for years, we were doing no telemedicine. And a big reason for that was because there was no reimbursement for primary medical care and telemedicine in Ohio at that time. So, you know, I think when we think about telemedicine, we really have to look at the way that telemedicine has been opened up by really shedding state regulation in a matter of weeks that opened the doors for us to be able to do things and get paid for it. So we're very fortunate. We're part of what's called a health center controlled network as far as our EHR deployment. So our electronic health record is hosted by an organization called OCHIN. Craig and I were talking about that on the prep call. And they have a deep background in telehealth and telemedicine from the West Coast, where, you know, of course, there's a lot more advancement there than we saw in Ohio. I'm also on the board of OCHIN, so I was very familiar with what could be done. And I think we've looked longingly at some of these other states for years thinking, you know, how could we do this? And we had sent one of our young docs, he's an amazing techie, to become a physician builder so that he actually could get like behind the screen, like the Wizard of Oz, and understand, you know, how the tech was deployed and all of that. So when telemedicine hit, I also have another doc who's a public health force with the public health department. And they basically sat me down and said, Jean, it's not safe to bring people into the office. And here's what we're gonna do. Chad, who's the young doc, he also has his dad works for us. So he said, and here's what we're gonna do. And so he figured out the platform that he felt we could implement most quickly. And he said, I can do it. I figured out how to do it. And if I can teach my dad to do it, I can teach anybody to do it. So we immediately, when the pandemic hit, you know, started transitioning and giving elbow support to all of our providers and said, here's your laptop, here's what you're going to do. And, you know, we got like 2 screens in the room, and put, you know, our medical director put one on a bucket and one on a this, and we just started going at it. And that's how we started. So when the FCC grant became available, we looked at this and thought, how are we going to get money to buy the equipment that we need so that we don't have one screen on top of a bucket and one screen on the swing arm that has our EHR? Because really, for us to do an office visit effectively, we need to have a communication device where we're seeing the patient's face, ideally. Some are telephone, but, you know, in most cases we want to see the patient's face. And then, you know, we've got the EHR screen so that people can be efficient in terms of delivering care. And so the only way, the path forward for us was to do that. So we looked at that, but then we also looked at what the FCC was looking for, and we decided to dream big and think, well, wouldn't it be great if down the road, we don't know how long the pandemic's going to last. I mean, at that point, we were hoping it would be months. Now, you know, we can talk about that. But we've also got all these homebound folks. And so wouldn't it be great if we could get home equipment that was Bluetooth enabled so that we could effectively care for patients with chronic illness? Because as anyone who works in community health knows, one of the biggest disadvantages for patients is lack of transportation. So this was also an opportunity in looking at the FCC grant to say, you know, maybe there's a lot of things that we can do that don't require an office visit. So can we set up a system and a vision that we could communicate through this FCC grant so that we could not only be caring for patients safely with the patient in their home and the primary care provider or behavioral health provider being in the office, but then wouldn't it be great, because we have nurses and all, wouldn't it be great if we could also take care of many of these things and get up-to-date vital. The grant was looking at COVID specifically. So we had already had docs that were saying, where are the pulse oximeters to send out to the patient's homes? I don't know if these people are going to crash, you know, and die on me. And so how can we get that stuff out there? And so we also included in our grant so that we could do that. Implemented this. We also bypassed the portal that was available to us through Epic, because at the time, and this is still the case, it requires a patient to be signed up with MyChart, patient portal, and then once they're signed up with MyChart, then they can access the visit and all that through Epic. But we chose to bypass that because that was an additional barrier. Because try as we may, and we really believed that, you know, people think that poor people don't have access to technology, and that's really not true. Vast majority of people that we serve have access to it, at least a smartphone. But try as we may, even with that access that we had, we were still only able to get about 40% of our patients up on MyChart regularly using it. So at the point when we started in on the pandemic, that's what we were looking at. So we needed to pivot to a platform that bypassed that and didn't set up a barrier. So that's another thing that, you know, as we go through the remarks, we tried to look at, you know, what are the barriers? And I think when we get into the questions with Craig and Geoff, we can talk about those barriers that we still see in communities of poverty and urban communities, which has not been the hotbed of telemedicine before the pandemic. What are those barriers in urban communities that would keep people from really being able to interface with their medical care and behavioral health providers through telemedicine? I have to say just a couple of things in closing before we get to questions that right now I have behavioral health workforce working from home, doing 100% telemedicine with we also did a digital satisfaction survey last people who had seen us over the past 3 months. And even with the complete pivot from our model of care that we had prior to the pandemic, our patient satisfaction had not diminished. And we were very, very pleased, considering that right now we're in medical, 80% still telemedicine and 20% face-to-face, that our patients still felt like they were being cared for in the same high level of care that's been our history. So, we're a believer. We're going to stay the course. We're trying to figure out in the midst of, our in Ohio, the counties go from, red to purple to orange, so we're still in the middle of all that. What's this going to look like 6 months, a year? We think that telemedicine is going to be a huge part of our vision going forward. We don't know at what percentage, but, we're just super pleased. And we're super pleased that we got the FCC resources for 300 kits for the home, as well as these really nifty, like cows or whatever they call them on wheels, where we get the 2 screens, and so our providers can comfortably, sit and do telemedicine for the majority of their day. So thanks so much. I'm so super happy to be here. And Craig, I'll turn it back to you for our questions.
Okay. Thank you very much, Jean, and also Geoff. You guys have some really interesting projects going on, and I definitely want to follow those a lot over the next few months. I have some questions. I'll start with Geoff. We have a lot of people here from the broadband world, and Chattanooga's network is fairly well known. Geoff, do you think that having a stellar network, right, that's doing a lot of innovation stuff in general, was that very helpful for you?
Oh, absolutely. The presence of the network and the entity that manages that network, EPB, is a fabulous community partner in so many ways. But particularly when we think about the needs of telehealth in particular, having fiber, having symmetrical connectivity, so that what I'm sharing with you is as high quality as what my healthcare provider is sharing back. Mm-hmm. Hugely important. And knowing that we could lean on that resource, and not just lean on it for a handful of people, but at least those within their service footprint, we would be able to get service to any home or business.
Mm-hmm. Now, one of the things I have noticed from other conversations with broadband administrators and so forth is that their attitude is, I built it, you now have it, I have nothing else to do with that network. Question is that a smart attitude to basically have no kind of connection with the broadband provider after the network has been built? And what's your thought?
No, I would absolutely push back on that. And actually, I'll see if I can pull in something Jean said, particularly about the providers doing this for the first time as well. That for our users and providers both, sort of the expectation that, okay, this is here, you figure out how to use it without any sort of support, without any sort of that kind of ongoing relationship, does not mm-hmm. lead to the outcomes we're looking for. It is about a relationship, and it is about providing, at a very basic level, digital literacy. But as you move through in the innovation space, that relationship is crucially important too.
Mm-hmm. So I definitely will echo that sentiment when I talk to other folks, because it does, in my mind, that those applications that run across the network, I think that as a broadband owner, you cannot be a passive participant, especially with the more innovative applications that are running across the network. Jean, I have a question for you. you were one of the first to get the grant money for telehealth, and you mentioned that you're able to get a lot of valuable equipment and so forth. Does the fact that there was no provision for the infrastructure, does that have an effect on you and your patients, or your patients not having a good broadband connection?
So I unfortunately can't speak to the quality of of who has a strong internet connection in their home. But it definitely, when we actually went into the telemedicine world, we weren't really considering that, but we knew that we would have barriers there. And we definitely have folks, and I'm talking about this with my team a lot now. So if you consider the person who's got chronic illness and is older, they're also the one that is less likely to be tech savvy, and they're also the one that's less likely to have broadband access. And so I think that's a real issue, is how do we get internet access to those individuals? And will we be able to teach them to use the technology? Will we have to deploy, if you look at it from a patient safety point of view, is it better to deploy a community health worker to the home with a tablet, or is it better to bring the patient into the office? Like, which is more safe? One of the things that we're talking about is basically having patients drive up in their car, and we give them a tablet. And then they wouldn't have to enter the facility, which puts them at higher risk, but they basically can key off our Wi-Fi. And so we're talking about that. I mean, some of these things seem really clunky, but when you consider the high risk of transmission of COVID, you don't want to have particularly someone who's most at risk sitting in your waiting room. So I know there's a health center in North Carolina, in Eastern North Carolina, that has been a real leader in telemedicine. And she's on the OCHAN board with me, and they have actually set up something in their parking lot so that people just pull in, and they're just doing tons of visits that way in a rural setting because of that access. But I think it's not your direct question, Craig, but I think that a concern that we have nationally in terms of policy is, what are we going to do with folks with telephone only? Now, I know when I talk to my medical care providers that they feel that a telephone only visit is marginally effective, whereas a video visit is much more effective. Behavioral health, not so much, so they're saying that they feel that it's very valuable. It's more valuable certainly to have the video, but to have a telephone visit. And so we're very concerned about public policy going the other way, where the telephone only visits are no longer reimbursed. I think that there might be a push to do that, both for behavioral health and for medical care. And I feel that is a very big concern, because for providers like mine, or again, back to the 21,000 people, if I've got, say, 80% they can deal with it. If their daughter comes over with a smartphone, they can figure it out, whatever, because people are they're figuring it out. But then you got that group of people, homebound seniors, people who don't speak English oftentimes, or like our refugee community oftentimes has literacy issues. So how are we going to really address ourselves to that? Because we don't want to have two standards of care.
Well, definitely not wanting to do that. I have the impression that there's policymakers that want to focus on the broadband, and then we have other people wanting to focus on the telehealth side of things. But I feel that these policies need to be put together in having both those people involved, right? And I think that you as a recipient are going to be better served if there's someone waiting to provide broadband and maybe enhanced telephone services to go along with your telehealth application. Does that make sense?
Oh, absolutely. And I think that the thing that we haven't talked about, well, so two things. One is, you know, on the west side of Cleveland, we've had instability of the network for a long time. It's getting better, but you know, trying to deploy 100% paperless EHR, that requires a lot of bandwidth too. And so, you know, that has been a real concern. And when we open up other sites, you know, that's one of our biggest hurdles, is making sure that we've got enough connectivity and that we've got, you know, duplication of, you know, we've got two ways in and switches and stuff, because, you know, we're highly dependent, you know, on that infrastructure. But I think the thing that we haven't touched on in the conversation is this isn't just about healthcare. Health is all encompassing, and the social determinants of health and health disparities include things like education, the ability to apply for a job, ability to apply for benefits online. So, you know, this digital divide affects, you know, the healthcare visit for sure, but the overall health of folks who are marginalized and don't have broadband is an issue.
Gotcha. Okay. Geoff, when you guys were, you know, thinking about telehealth, and before the grant kind of came together, was there a plan specifically in place to address the Aleo services?
No, so you know, our approach was first in recognizing there was an opportunity from the FCC, was as a community and as, you know, a partner who thinks deeply about both equity and economic development. You know, how can we get these funds to help stand up some of this infrastructure, to help get us started in a new way to Chattanooga? Who are the partners we have? And we've been having conversations through Aleo and hospice about, particularly, as Jean says, the social determinants of health. How could our digital equity work, the systemic nature and systems level opportunities around broadband access support their work to begin with? So it became a natural partnership, and especially to bring in our provider. I'll add to the conversation that I think, you know, as we think about high-speed access as a utility, like water, et cetera, you know, when you've got that, that means that access to quality healthcare, like exactly what Jean and her team are doing in Cleveland, becomes that same kind of utility that everybody has access to, that becomes a much more equitable opportunity for our communities and feeds into that cycle of community health, along with those other things that she brought up.
Now, did EPB have to partner with a rural service provider to help the whole project come together?
Yeah, so that was the other piece, was right. All of our various footprints are not the same, but our care for our community is. And finding a way not to sort of delineate based on geographic borders, but on who needed this service. How do we do that? And so that was looking at everybody else in the space who could provide access, and how we would be able to get the same or close to the same level of access in those homes for those patients, and for those providers, using whatever means we had. Again, this community approach, it is about the outcomes. And so, you know, we shifted a little bit what the partnership could look like.
Jean, I have a question regarding consortium. So in the one of the FCC's other programs, the Rural Healthcare Program, they are very heavily weighted toward consortiums between big hospitals, maybe urban hospitals, and rural hospitals at the practice level, at the, you know, the small independent processes. Does it seem viable, worthwhile, to have a practice like yours partner with bigger healthcare providers in order to help everybody in the chain?
Yeah, I think the answer to your question is clearly yes. Now, when we look at what's going on in Ohio right now, I don't know that that is a short term, because the hospital providers, I actually was very proud of our organization as a small nonprofit, that we pivoted to telemedicine. Some of the hospital primary care docs that I talked to, that their telemedicine wasn't as, they didn't work on their workflows, and now they've pivoted back to more face-to-face. When we put telehealth in our strategic plan for next year, before we were thinking, here's what we were thinking, that we were going to keep a patient who doesn't travel well because they have interpretation, all the reasons that people don't trust. They don't want to go to the hospital with a big parking garage, and we've got Cleveland Clinic and university hospitals, and these monolithic structures. And so we thought that we would use telehealth patient like myself sitting in neighborhood family practice office, but I would get a virtual specialty care visit. And I still think that there's some opportunity there. I think the thing that I'm realizing, because the hospitals, I had conversations with them, they're very, a lot of things that are in their business model right now, which is not the purpose of this call. And they also have, of course, a visit that's also got a facility fee attached to it. And I think that when you look at the cost of healthcare going forward, it's occurred to me that the specialty care that I'm discussing does not necessarily need to be delivered locally. I mean, there's certainly, if you look at like Project Echo and things like that, and it was very focused, on specialty care and all that. And then the idea, you use the remote provider for your specialty consult, but then if they need to see the person face to face, it's that same person. But the reality is, I think in the world that's coming, that's not necessarily the case. So if you look at, if I'm in a contract, which I'm not, we're too little, but at organizations like a federally qualified health center that are going to be in risk-based, my local hospitals would have to be cost effective. And so I think that we're going to see a lot of disruption, where organizations are going to say, hey, I can provide that service to your patients. Like if they need a exam for their diabetes, there's no reason that it has to be, Dr. Jones down the street. That, if they do need a face-to-face visit or they need surgery with an ophthalmologist, yeah, we can get that for you later. But there's just so much, I believe, that we send out as primary care to specialty care that could be done remotely. And I think we haven't even begun to scratch the surface of. And now that we've found patients can be so comfortable with a video visit, and let me just say something about that. What we have found is that our no-show rate has gone down so much because people don't have to take 3 hours anymore. They can get their concern taken care of, like, they when they're on, the boom, and they're done. And behavioral health, they love it. The patients just love it. And I think that we didn't even realize, I mean, just like I'm doing a webinar from home, like who knew, right? I think the beginning of, I think we haven't even thought, we're so relationship, so face-to-face based in healthcare. Our whole structure's been built around it. And I think we have to open up our minds and say, what is really the best for the patient? And what is the most efficient for them, and what is going to get their needs met most, in the best possible way. And I think that there is a lot of ways that telemedicine is going to meet particularly younger patients in a way that is going to be completely for the healthcare industry.
So, Geoff, I have a question related to training. In your experience, did your partners allow for any kind of like money for training, sort of the incidentals of making this service valuable? Was that a factor in your planning, or is this going to be something that has to be addressed later, do you think?
So, for this particular opportunity, it wasn't really an option. But because of sort of this partnership model, we knew how important it was, and looked at how we could surround, this funding opportunity to get some of those big things out of the way, including the connectivity, and figure out where we could get that support for training, and particularly, in this moment in time, reiterate Gene, as I'm going to do for the rest of a very long time, thinking about, we have had this shared experience of what the digital divide is, what life remote is, and being able to leverage a little bit of that as well into, for partners who may not have considered that, that sort of training, even just turning the device on, being important. When you see and everything has to go remote, how absolutely vital those skills, and how, learning them in context helps them translate, really understood how important that was, and made that conversation about, we do need to go out and find funds to make sure that this is part of the process, especially for, again, as Gene said, the folks in our group who are most likely to be disconnected, least likely to have these kinds of devices at home, and least likely to feel comfortable with them. It was crucially important.
Mm-hmm. So, Gene, from your perspective, was either training of your staff or training of your patients, was that factored into the plan? Is this sort of a separate effort that has no relationship to the proposal that you submitted? Where did the training part, again, for both the patients and the staff, come into the picture?
So, so there wasn't a specific training plan. I think this was sort of battlefield conditions. But we did have both a provider builder in behavioral health, Paul and Chad on the medical side, who sat down every individual and walked it through. And then, we have some on teams. They're more like support, application support folks. We've just kept working our, tuning up our workflows. And so we've constantly been pushing out, training that way internally. So we didn't have a plan per se, but we're constantly looking at it. Just one other thing I'll say is that it's also caused us to do things like we started to use another application where we could do, it's called Jotform, where we could do, have people be able to sign up for testing. We're doing COVID testing. We're figuring out other ways that we can use technology we send people links to sign up and things like that. So we didn't really do that training that way. And I'm sorry, Craig, I lost the second half of your question.
No worries. We're almost, we got about 5 minutes. So I actually want to get one last question for both of you, which is the question of actually preparing the proposal. Did you guys hire or retain some sort of grant writing ninja, or how did you address the issue of making this grant worthy of the FCC's money?
Well, I can start if you want. I remember sitting in a conference room, our command center, right? And when the grant hit, it was a quick turnaround. And they said it was rolling, right? And we write lots of federal grants, so we have some in-house stuff. And I said to Chad, who I've said is the guru there, I'm like, hey, we can apply for up to this, up to this amount of money. It was $1 million, but we knew we didn't need that much. We applied for 350, we got 33. And he's like, how does federal money work? Is it like monopoly money? I'm like, no, but you can't get the money if you don't apply. So,
right.
So we're like, we knew, I'm like, okay, what's the vision? And we had the application specialists running off and getting phone quotes and this one, right? We just said figure this out, figure this out, figure this out. And then we took our grant writing team, like I said, federally qualified health center. We have an in-house and contract grant staff. And,
Mhm.
and we were like on that telehealth website, and the minute it opened, you know, it was sitting there waiting. And we got it in. I think one of the reasons we were funded early is we were motivated. We had a big vision, and we hours after they opened the portal. So I think that's, you know, we knew that we needed this money. Health centers, we get operating dollars, but we don't get capital. And so we're like, we're never going to have an opportunity like this. We got super excited about it. Everybody just was like, yeah, we're really slammed. The pandemic's just starting, but we're going to get this done because this is really important for our patients.
Got it. So
Craig,
Geoff, I got a minute. How did you address the grant writing process? Did you have experienced people, or did you hire somebody?
Well, I'm going to add grant writing ninja to my resume. Thank you for throwing that phrase out. So that was one of the things that we as a partner were able to bring is some expertise in grant writing. And my partner over at Aleo, who was coordinating this, is head of the Foundation for Hospice of Chattanooga, and had a lot of experience in the grant space as well. And so we just pulled resources, figured out what everybody could tackle, jumped on it, and sort of that same idea as Jean shared. But let's get this done.
Great. All right. Well, that's about it for today. I want to thank you, Geoff, and also you, Jean, for being with us today and sharing some of your insights and everything that was involved with your race for the money. And so we hope that others who are watching will take some good ideas from both of you and apply this in the other types of grants that are being pursued. It's been very helpful. Now I want to make sure, reach out to us, this is to the audience, reach out to all three of us, and we can answer probably any kind of question that you have regarding broadband, telehealth, bring them two together. Thank you again for your time.